Hello, this is Dr. Francis narrating the PowerPoint for end-stage liver disease. It's a chronic progressive disorder of the liver where the cells attempt to regenerate, but they are disorganized. It results in abnormal architecture and overgrowth of the cells, which then impede or limit the blood flow. The liver attempt, but the regeneration process is disorganized, and the overgrowth is more fibrous of the connective tissue, and it distorts the liver's lobular structure, and thereby having no blood flow or limiting the blood flow. Eventually, the irregular and disorganized liver has poor cellular nutrition and hypoxia results, which then causes more scar tissue and decreases the functioning of the liver. The development of cirrhosis can be insidious and prolonged course, which slow to show symptoms. Cirrhosis combined with chronic liver disease is ranked as the 8th leading cause of death in the United States, and it's twice as common in men as in women. DL is a 35-year-old woman admitted from the emergency room with a diagnosis of hepatic encephalopathy. Review of old medical records indicates a diagnosis of fatty liver disease at the age of 29 and cirrhosis at the age of 31. She accepts treatment only during crises. What else would you look for in DL's past medical history that might be a precipitating factor in liver disease? Unfortunately, one of the number one causes is abuse of alcohol. So you would ask or inquire about how much drinking she does, whether or not she drinks every day. Of course, you have to leave open-ended questions in order to elicit the correct information. Any chronic liver disease, including excessive alcohol intake, and also NAFLD is non-alcohol-related liver disease, can cause cirrhosis. The specific cause of cirrhosis may not be determined in all patients. The most common causes of cirrhosis in the United States are chronic hepatitis C infections and alcohol-induced liver. In patients with alcohol-induced liver disease, there's controversy exists as to whether the alcohol is the cause of the malnutrition that can coexist. A common problem in alcohol patients is protein malnutrition. This may have caused the nutrition-related cirrhosis resulting in extreme dieting, malabsorption, and obesity. Environmental factors and a genetic predisposition may also cause the development of cirrhosis, regardless of dietary intake. Approximately 20% of patients with chronic hepatitis and 10 to 20% of those with chronic hepatitis B will develop cirrhosis. Chronic inflammation and cell necrosis results in fibrous tissue and ultimately cirrhosis. Chronic hepatitis combined with alcohol ingestion is synergistic in accelerating liver damage. The liver will begin to become distorted and enlarged, and this is secondary to alcoholism. The characteristic of this diffuse nodular of the surface is due to the combination of the regeneration and then the scarring of the liver. Biliary cirrhosis includes primary biliary cirrhosis and primary sclerosing cholangitis. Primary sclerosing cholangitis is a chronic inflammatory condition affecting the liver and the bile ducts that is frequently found in men. Cardiac cirrhosis includes a spectrum of hepatic disarrangements that result from long-standing severe right-sided heart failure, and the treatment is aimed at managing the patient's underlying heart failure in hopes that it will improve the perfusion through the liver. What late clinical manifestations of cirrhosis would you assess in DL? So as the disease is allowed to progress, the normal functionings of the liver becomes impaired. One of them is the ability to conjugate bilirubin and then have it travel through the biliary tree and be dispersed into the GI tract. If that is impaired, the bilirubin may back up and then go into the bloodstream and cause the patient to have a presence of yellowing, which from the bilirubin, which is called jaundice. The second side effect of a malfunctioning liver could be the inability to synthesize albumin, and then that would cause the patient to have the disruption in their osmotic pressure and have leakage or third spacing of the fluid. The onset of cirrhosis is usually insidious. Early symptoms can include fatigue. Many patients with normal liver function, compensated cirrhosis may not be aware of their liver condition. The diagnosis may not be discovered until later when they present with the symptoms of more advanced liver disease. Later symptoms may be severe and result from liver failure and portal hypertension. If we remember when we discussed in patho that the portal hypertension is a result of congestion within the vessels and the inability for the blood to flow into the major liver vessel, which is known as the portal vein. If there is a blockage, then there becomes an overflow, and that's what causes the hypertension in the portal vein, otherwise known as portal hypertension. Jaundice, peripheral edema, and ascites may develop. Other late symptoms include skin lesions, hematological disorders, endocrine disturbances, peripheral neuropathies, and in advanced stages, the liver becomes small and nodular. Jaundice results from the functional derangement of the liver cells and the compression of the bile ducts. The bile ducts is what connects the liver and the gallbladder. If that is not a patent duct, then there is a backflow. The jaundice occurs as a result of the liver's decreased ability to conjugate and then excrete bilirubin. The jaundice may be minimal or severe depending on the degree of liver damage. The skin lesions are due to an increase in the circulating estrogen caused by the inability of the liver to metabolize the steroid hormone. An increase in circulating estrogen as a result of the damaged liver and its inability to metabolize them. What you'll see is spider angiomas, are small dilated blood vessels with bright red centers and spider-like branches. They occur on the nose, cheeks, upper trunk, neck, and shoulders. Palmoerythemia, a red area that blanches with pressure, is located on the palms of the hand. The hematological disorders that include thrombocytopenia, leukopenia, anemia, and coagulation disorders. Thrombocytopenia, leukopenia, and anemia are probably caused by the splenomegaly. Splenomegaly results from the backup of blood from the portal vein into the spleen, which causes the portal hypertension. Portal is just another name for the vessel that runs through the liver. Overactivity of the enlarged spleen may result in increased removal of blood from the circulation. Anemia is due to inadequate RBC production and survival, poor diet, poor absorption of folic acid, and bleeding from the varices. The coagulation problems are a result from the liver's inability to produce prothrombin and other factors essential for blood clotting. Coagulation problems are manifested by hemorrhage or bleeding tendencies, such as epistaxis, purpurea, petechiae, easy bruising, gingival bleeding, and heavy menstrual bleeding. Normally, the liver is important to the metabolism of the adrenocortical hormones, estrogen and testosterone. In men with cirrhosis, gynecomastia, which is the benign growth of glandular tissues of the male breast, loss of axillary and pubic hair, and testicular atrophy, impotence with loss of libido may occur because of increased estrogen levels. In younger women with cirrhosis, amenorrhea may occur, and in older women, there may be some vaginal bleeding. The liver fails to metabolize aldosterone adequately, resulting in hyperaldosteronism and subsequent sodium and water retention and potassium loss. Peripheral neuropathy is common finding in alcoholic cirrhosis and is probably due to a dietary deficiency of thiamine, folic acid, and cobalamin. The neuropathy usually results in mixed nervous system symptoms, but sensory symptoms may also predominate. Patients without complications of cirrhosis have compensated for their liver disease. Those who have one or more complications of their liver disease have decompensated cirrhosis. Major complications of cirrhosis are portal hypertension with resultant esophageal and or gastric varices, peripheral edema and ascites, hepatic encephalopathy, mental changes including coma, and hepatorenal syndrome. Portal hypertension results from obstruction to the normal flow of blood through the portal system, secondary to structural changes in the liver, which cause compression and destruction of the veins and the sinusoids. Portal hypertension is characterized by increased venous pressure in the portal circulation, as well as splenomegaly, large collateral veins, ascites, gastric and esophageal varices. Collateral circulation develops in an attempt to reduce portal vein pressure and also to reduce the increased plasma volume and lymphatic flow. The most common areas where the collateral channels form are the lower esophageal, the anastomosis of the left gastric vein, and the azygous veins, the anterior abdominal wall, the parietal peritoneum, and the rectum. Varicosities may develop in areas where the collateral and the systemic circulations communicate, resulting in esophageal gastric varices and the ring of varices around the umbilicus and hemorrhoids. Esophageal varices are a complex of tortuous veins at the lower end of the esophagus, which are enlarged and swollen as a result of portal hypertension. These veins contain little elastic tissue and are very fragile. They tolerate high pressure poorly, and the result is that they can bleed easily. Large varices are more likely to bleed. Esophageal varices are responsible for approximately 80% of the variceal hemorrhages. Bleeding esophageal varices are the most life-threatening complication of cirrhosis, and the patient may have melena or hematemesis that may be slow oozing or a massive hemorrhage. Massive hemorrhage is a medical emergency. Gastric varices are located in the upper portion or otherwise known as the cardia or the fundus of the stomach, and they account for 20% of all the varices. Peripheral edema is due to the diminished collotic oncotic pressure from impaired liver synthesis of albumin and an increase in the portal cable pressure from portal hypertension. Peripheral edema occurs typically at the ankle or the presacral area. Ascites is the accumulation of serous fluid in the peritoneal or abdominal cavity. Ascites is manifested by abdominal distension with weight gain, and it is a common manifestation of cirrhosis. It is the pathophysiology map that you see here is found on page 989 of your textbook. And what occurs is with portal hypertension, proteins shift from the blood vessel via the large pores of the sinusoids into the lymphatic space. When the lymphatic system is unable to carry off the excess protein and water, they then leak the liver capsule into the peritoneal cavity. The osmotic pressure of protein pulls additional fluid into the peritoneal cavity. The second mechanism of ascites formation is hypoalbumin, resulting from the inability of the liver to synthesize albumin. The hypoalbumin results in a decrease in the collotic oncotic pressure. A third mechanism is hyperaldosteronism, which occurs when aldosterone is not metabolized by the hepatocytes. The increased level of aldosterone causes increased sodium reabsorption by the renal tubulars. The retention of sodium, as well as the increase in the antidiuretic hormone, causes additional water retention. Because of edema formation, intravascular volume is decreased. Subsequently, renal blood flow and glomerular filtration are decreased. The patient has signs of dehydration, skin, eyeballs, muscle weakness, and there is also a decrease in urinary output. Hypokalemia is a common and is due to an excessive loss of potassium caused by hyperaldosterone. Low potassium levels can result from a diuretic therapy used to treat ascites. Because of the alterations in immune function associated with cirrhosis, patients with ascites are at risk for spontaneous bacterial peritonitis. Spontaneous bacterial peritonitis is a bacterial infection of the ascites fluid. This occurs in approximately 15 to 20% of hospitalized patients with cirrhosis and ascites, and is particularly common after variceal hemorrhage. The bacteria most found is gram-negative E. coli. Here is a picture. Ascites is manifested by this abdominal distension with weight gain. If the ascites is severe, the umbilicus will become everted. An abdominal stridor with distended abdominal veins can be seen. What might be causing DL's current episode of hepatic encephalopathy? What specific clinical manifestations related to hepatic encephalopathy would you expect DL to have? So hepatic encephalopathy is the confusion associated with liver disease, and it's due to the fact that the breakdown of RBCs leads to an increase in ammonia, and the body is not able to rid itself of the ammonia, and it travels to the brain and it crosses the blood-brain barrier, and patients have neurotoxic symptoms. One of the other complications is hepatorenal syndrome can occur in patients with decompensated cirrhosis. It is a type of renal failure with advancing azotemia, oliguria, and intractable ascites. The syndrome is not characterized by structural abnormality of the kidneys. The etiology is complex, but the final common pathway is likely to be portal hypertension along with liver decompensation that results in splenic and systemic vasodilation and decreased arterial blood volume. As a result, renal vasoconstriction occurs and renal failure follows. The renal failure can be reversed by liver transplant. In the patient with cirrhosis, hepatorenal syndrome frequently follows diuretic therapy, GI hemorrhage, and/or paracentesis. The hepatic encephalopathy is a neuropsychiatric manifestation of liver disease. The pathogenesis of hepatic encephalopathy is multifactorial and includes the neurotoxic effects of ammonia, abnormal neurotransmission, astrocyte swelling, and inflammatory cytokines. A major source of ammonia is the bacterial and enzymatic deaminization of the amino acids in the intestines. The ammonia that results from this deamination process usually goes to the liver via the portal circulation and is converted to urea, which is then excreted by the kidneys. When blood is shunted past the liver via the collateral vessels, or the liver is unable to convert ammonia to urea, the levels of ammonia in the systemic circulation increases. The ammonia crosses the blood-brain barrier and produces neurotoxic manifestations. The clinical manifestations of encephalopathy are a change in neuro and mental responsiveness, impaired consciousness and or inappropriate behavior, ranging from sleep disturbances to lethargy to a deep coma. Changes may occur suddenly because of an increase in ammonia in response to bleeding, varices, or infection, or it may arise gradually as blood ammonia levels slowly increase. A grading system is often used to classify the stages of hepatic encephalopathy, 0 to 4, 4 being the most advanced. A characteristic manifestation of hepatic encephalopathy is astigmatis, flapping tumors. This may take several forms, and the most common involving the arms and hands. When asked to hold their arms and hands stretched out, the patient is unable to hold this position, and a series of rapid flexion and extension movement of the hands will develop. The grading system for hepatic encephalopathy is found on page 990 of your textbook. The effector hepatitis is a musty, sweet odor of the patient's breath that occurs in patients with encephalopathy. The odor is from an accumulation of the digestive byproducts that the liver is unable to degrade. A continuation of liver disease and cirrhosis and resulting manifestation. As you can see, almost every symptom of the body is affected by liver disease. The picture is located on 988 in your book. You can have neurological symptoms from the hepatic encephalopathy, peripheral neuropathy, and the asterisk. The GI complications, anorexia, dyspepsia, nausea, vomiting, change in bowel, dull abdominal pain, the fetor hepatitis, esophageal and gastric varices, gastritis, hematemesis, and hemorrhoid varices. Reproductively, they might have amenorrhea, testicular atrophy, gynecomastia, or impotence. They might also, on their skin, have jaundice, spider angioma, palmar erythema, purpura, petechiae, and cap-tube medusa. Hematological complications include anemia, thrombocytopenia, leukopenia, coagulation disorders, and splenomegaly. Metabolic, we might have hypokalemia, hyponatremia, and hypoalbuminemia. Cardiovascular is fluid retention, peripheral edema, and ascites. What diagnostic test would you expect the healthcare provider to want to do for DL? DL, in cirrhosis, there are abnormalities in most of the liver function studies. Enzyme levels including alkaline phosphatase, AST, ALT, and GGT are initially elevated because of their release from damaged liver. However, in end-stage AST and ALT may be normal. In cirrhosis, total protein and albumin levels are decreased, Serum albumin and globulin levels are increased. Fat metabolism abnormalities are reflected, decreased cholesterol levels, and the prothrombin time is prolonged, and bilirubin metabolism is altered. A liver ultrasound may be useful to assess the severity of the cirrhosis, and a liver biopsy may be done to identify liver cell changes and alterations in the lobular structure. Differential analysis of acidic fluid may help confirm the cause of the cirrhosis. DL's lab values are total bili of 11, AST of 80, ALT of 70, LDH of 700, and ammonia level of 220, and the white blood cell count is 21. DL is thin and malnourished with ascites, marked edema on lower extremities, and both her liver and spleen are palpable. Liver and spleen should not be able to be palpable, so thereby, by that physical assessment, you know that they are enlarged. Jaundice and spider angiomas are present, and there is evidence of bruising throughout her body. The bruising is probably due to the deficient amount of platelets due to the fact that the liver is not producing enough of the platelet factors. What would be your priority of care for DL? The priority of care for someone with liver disease would be to try to stop the progression of the disease. So one of the first things that would happen is to determine whether or not alcohol is a factor and provide some education. From there, we would want the treatment is the progress and prevention of any further complications. We would have rest, the B complex vitamins, avoidance of alcohol, and minimize the avoidance of aspirin, acetaminophen, and NSAIDs. What specific treatment measures would be helpful for the ascites? As the abdomen grows, it becomes a potential complication for breathing because it impedes the ability for the lungs to fully expand, and then we'll have inadequate gas exchange. For the ascites, it's very helpful to have sodium-restricted diet, diuretics, and fluid removal. The amount of sodium restriction is based on the degree of ascites. Initially, the patient might be encouraged to limit intake to 2 grams a day. Then it might have to go down as low as 250 to 500 milligrams. Very low sodium can result in reduced nutritional intake and then further complicate or compound the malnutrition. The patient is not usually on restricted fluids unless severe ascites develops, because remember, essentially they are dry. Accurate assessment and monitor flow and electrolytes. Albumin infusion may be useful to help maintain vascular volume and adequate urinary output by increasing the plasma colloid osmotic pressure. Diuretic therapy is important because of the management. Often a combination of drugs that work at multiple sites in the nephron is most effective. Spironolactone is an effective diuretic, even in patients with severe sodium retention. Spironolactone is an antagonist of aldosterone and is potassium sparing. A high potency loop diuretic, such as furosemide Lasix, is frequently used in combination with a potassium sparing drug. Tolvaptan Samsca, a vasopressin receptor antagonist, is used to correct the hyponatremia in patients with cirrhosis. It causes an increase in water excretion, resulting in an increase in sodium concentration. A paracentesis or a needle puncture of the abdominal cavity may be performed to remove the acidic fluid or to test the fluid for infection. Reserved for patients with impaired respirations or abdominal pain caused by the ascites. It is only a temporary measure because the fluid will reaccumulate. Transjugular intrahepatic portosystemic shunt TIPS is used to alleviate ascites that does not respond to the more conservative method of diuretics. Peritoneal venous shunt is a surgical procedure that provides continuous reinfusion of the acidic fluid into the venous system. It can cause complications where we could have bacteremia from infected acidic fluid, so that would have to be monitored for. The main therapeutic goal for esophageal gastric varices is to prevent the bleeding and hemorrhage. The patient who has esophageal varices should avoid alcohol, aspirin, and NSAIDs. All patients with cirrhosis should have upper endoscopies to screen for the presence of the varices. The diagnosis of esophageal or gastric varice bleeding needs to be made by endoscopic examination as soon as possible. Patients with varices at risk of bleeding are started on a non-selective beta blocker or propranolol Inderal to reduce the incidence of hemorrhage. Beta blockers decrease high portal pressure. When variceal bleeding occurs, the first step is to stabilize and maintain the airway. As you know, the esophagus and the trachea run right by one another. IV therapy is initiated and may include administration of blood products if the hemoglobin gets low. Management that involves a combination of drug therapy and endoscopic therapy is more successful than either approach alone. Drug therapy for bleeding varices may include somatostatin analog, sandostatin, or a vasopressin. The goal of drug therapy is to stop bleeding so that treatment measures can be initiated. IV administration of vasopressin produces vasoconstriction of the splenic arterial bed, decreases portal vein blood flow, and decreases portal hypertension. However, VP has many side effects, including decreased coronary blood flow, dysrhythmias, and an increase in blood pressure. Because of this, IV nitroglycerin is often given in combination. The nitroglycerin reduces the adverse effects of VP while enhancing the beneficial effects. VP should be avoided or used cautiously in the older adult. Balloon tamponade may be used in patients with acute esophageal or gastric varice hemorrhage that cannot be controlled by endoscopy. A balloon tamponade controls the hemorrhage by mechanical compression of the varices. The types of tubes are available. The Sandostatin Blakemore tube has 2 balloons, gastric and esophageal, with 3 lumens. One of the gastric balloon, one for the esophageal balloon, and one for gastric aspiration. 2 other types of balloons include the Minnesota tube, which is just a modified Sandostatin Blakemore with an esophageal suction port above the esophageal balloon, and the LinkedIn necklace tube, which is not really utilized that frequently. And here is a picture of the ports and the balloon, and then as they inflate the balloon, it puts pressure on the outside of the varices to tamponade the bleeding. Label each lumen to avoid confusion and deflate balloons for 5 minutes every 8 to 12 hours per institutional policy to prevent tissue necrosis. Additional care that might be needed is the administration of fresh frozen plasma and packed cells. Vitamin K might also be beneficial. PPI, lactulose is given. Lactulose and rifampin are given to prevent the hepatic encephalopathy. It traps the ammonia in the intestine and has the body excrete it. Antibiotics could be given to prevent bacterial infection. Long-term management, because there is a high incidence of recurrent bleeding, long-term management is necessary. Patients might be on a non-selective beta blockers. They might need repeated band ligation of the varices or a portal systemic shunt to prevent patients who develop recurrent bleeding. Non-surgical and surgical methods of shunting away from the varices sites are available. Shunting procedures tend to be used more after a second bleed than for an initial intervention. Transjugular intrahepatic portosystemic shunts is a non-surgical procedure in which a tract shunt between the systemic and the portal vein system is created to redirect the portal blood flow. Various surgical shunting procedures may be used to decrease portal hypertension by diverting some of the portal blood flow and at the same time allowing adequate liver perfusion. Currently, the surgical shunts commonly used are the portal canaval shunt and the distal splenal shunt. And if you can look at this picture, you see that there is bleeding. And once the shunt is placed, this is the sheath that you see, it controls the bleeding. A portal venogram before the tip shows filling of the larger esophageal varices. After insertion of the tips, which is the B picture, intrahepatic portal vein flow is now reversed with the direction of intrahepatic flow towards the tips. The procedure is a catheter is placed into the jugular vein, then threaded through the superior and inferior vena cava into the hepatic vein. The wall of the hepatic vein is punctured and the catheter is directed to the portal vein. Stents are positioned along the passageway, overlapping the liver tissue and extending into both veins. This procedure reduces portal venous pressure and decompresses the varices, thus controlling bleeding. Here is another picture of a portal caval shunt. The portal vein is anastomosed to the inferior vena cava to the systemic circulation. Distal splenal renal shunt, the splenic vein is anastomosed to the distal renal vein, and the portal venous flow remains intact, with esophageal varices are selectively decompressed. The spleen conducts blood from the high-pressured esophageal and gastric varices to the low-pressure renal vein. What specific treatment measures would you expect a healthcare provider to order for DL's encephalopathy? So DL now has encephalopathy. You would expect at least some lactulose, which would be helpful. The goal or management of the encephalopathy is to reduce ammonia formation. Ammonia in the intestines is reduced with lactulose. This drug traps ammonia in the gut, and then it can be given orally or as an enema or through an NG tube. The laxative effect of the drug expels the ammonia through the colon. Antibiotics such as rifampicin may also be given, particularly in patients who do not respond well to lactulose. Constipation should always be prevented. Control of hepatic encephalopathy also involves treatment of the precipitating cause. This means controlling GI bleeding, removing the blood from the GI tract to decrease the protein in the intestines. There is no specific drug therapy for cirrhosis. It is really kind of based upon just treatment of the liver disease. Nutrition is of high concern. We want to reestablish the protein so that we can correct that osmotic pressure. High calories, 3,000 a day, high carbohydrates, and a moderate to low level fat. Protein restriction may be appropriate in some patients immediately following a severe flare of symptoms, such as hepatic encephalopathy. However, protein restriction is rarely justified in patients with cirrhosis and persistent hepatic encephalopathy. Malnutrition is a more serious clinical problem than hepatic encephalopathy for many of these patients, and we don't want to further compound that problem. A patient with alcoholic cirrhosis frequently has protein-calorie malnutrition, and for patients with protein malnutrition, enteral formula supplements containing protein from branched-chain amino acids that are metabolized by the muscle may be recommended. These supplements provide protein that is more easily metabolized by the liver. Parenteral nutrition or enteral nutrition may be required. The patient with ascites and edema is placed on a low sodium diet. The degree of sodium restriction varies depending on the patient's condition, and the patient needs instructions regarding the degree of restriction. Table salt is a well-known source of sodium, but sodium is also present in baking soda and baking powder. Foods that are high in sodium content, canned soup, vegetables, frozen foods, snacks, meats, fish, crackers, breads, olives, ketchup. Advise the patient to read labels and become aware of what foods have sodium in them. The patient and the caregiver need assistance to make the diet more palatable. They can use things such as garlic, parsley, onion, lemon juice, and other spices. Obtain the following data, whether or not they've been exposed to viral, toxic, or idiopathic hepatitis, NASH, chronic biliary obstruction, an infection, or severe right-sided heart failure. Medications, adverse reactions to any meds, the use of anticoagulants, aspirin, NSAIDs, and acetaminophen. Also obtain the following important information about whether or not they have any chronic alcoholism, weakness, fatigue, whether or not they've been experiencing anorexia, weight loss, dyspnea, nausea, vomiting, or any gingival bleeding. Also obtain the following important information. Is their urine dark, which is indicative of bilirubin? Has there been a change? Is their stool light colored or black, which could either mean a blockage in the biliary tree or bleeding, flatulence, change in bowel habits, and yellow skin, bruising, or dryness. Obtain cognitive, whether or not they've been having any confusion, techniques of their extremities, right upper quadrant, epigastric pain, or numbness, and have they had any problems with impotence or amenorrhea. They had fevers, cachexia, wasting of their extremities, icteric, sclera, jaundice, petechiae, ecchymosis, spiderangiomas, palma, erythemia, alopecia, loss of axillary and pubic hair, or peripheral edema. Are they having any problems with their respiratory status, GI, palpable liver, spleen, foul breath, black tarry stools? Are they having an ultramentation? Are the men having gynecomastia or testicular atrophy or impotence, loss of libido? Women, are they having amenorrhea or a heavy menstrual bleed? Possible diagnostics findings would be anemia, thrombocytopenia, leukopenia, a decrease in serum albumin level, hypokalemia, abnormal liver functions, an increase in their INR, increase in their ammonia, and an increase in their bilirubin level. Abnormal ultrasound studies or an MRI. There's an imbalance of nutrition less than body requirement, usually related to their anorexia or impaired utilization of the nutrients. Impaired skin integrity related to peripheral edema, ascites, and pruritus. Excessive fluid volume related to portal hypertension and hyperaldosteronism. Ineffective health management due to abuse of alcohol, ineffective coping, and dysfunctional family processes related to disruption or deterioration of the relationships. The overall goal is to provide comfort, to minimize complications such as ascites, esophageal varices, and hepatic encephalopathy, and return to a normal lifestyle. The common risk factors for cirrhosis include alcohol, malnutrition, viral hepatitis, biliary obstruction, obesity, and right-sided heart failure. Prevention and treatment of cirrhosis may focus on reducing or eliminating these risk factors. Alcoholism must be treated. Urge patients to avoid alcohol ingestion. Adequate nutrition is necessary. It is essential to promote liver regeneration. Identify and treat acute hepatitis so it does not progress to chronic hepatitis and cirrhosis. Bariatric surgery for morbidly obese individuals has been shown to have occurrences to reduce liver disease. The focus of your nursing care with cirrhosis is on conserving their strength. They should require bed rest, but then you're concerned about the hazards of immobility such as pneumonia, thrombolytic problems, and pressure ulcers. Modify the activity and the rest schedule. Anorexia, nausea, and vomiting. Pressure from ascites and poor eating habits can create problems with your nutrients. Allow for oral hygiene before meals. Make between meal nourishment available. Find out their food preference and explain the reasons for any dietary restrictions. Nursing assessment should also include their skin. Is there any jaundice? Is there any itching associated with it? Quastrin or Atarax can be helpful. Measures should be instituted to alleviate some of the pruritus. They should have calamine lotion. Their linen should be soft, and they should have control of the temperature. Their nails should be kept short so that they don't scratch and cause irritation. Note the color of their urine and stools. When jaundice is present, the urine will be brown and foamy, and the stool is gray or tan. Edema and ascites are frequent manifestations of cirrhosis. Accurate calculation and recording of INO, daily weights, measurement of the extremities, and the abdomen should be marked with a permanent marker so that the same location for their girth is every day. Immediately before paracentesis, the patient should void. When a paracentesis is done, the patient is on the bed and is placed in high Fowler's position. Following the procedure, you should assess for hypovolemia, electrolyte imbalances, and check the dressing for any bleeding or leakage. Dyspnea is a frequent problem for patients with severe ascites. High Fowler's is necessary to allow for respiratory efficiency. Pillows might be needed for the arms and legs. Meticulous skincare is essential because the edematous tissue can cause the subject to break down. Use an alternating air mattress or a special mattress, a turning schedule, support the abdomen with pillows. The patient tends to move very little because of abdominal discomfort, and range of motion exercises will be necessary. Implement measures such as coughing and deep breathing to prevent respiratory problems, and the lower extremity should be elevated. If scrotal edema is present, a scrotal support would supply some comfort. A patient with advanced cirrhosis who has ascites is short of breath and has an increase in respiratory rate. The nurse should D. Dyspnea is a frequent problem for the patient with ascites, and a semi-Fowler's or Fowler's position allows for maximum respiratory efficiency. Oxygen administration is not indicated. The SpO level would be an indication for oxygen. The respiratory distress is caused by the ascites, not by respiratory secretion, so coughing and deep breathing would not help to eliminate or alleviate the distress. Paracentesis may be performed to remove acidic fluid. However, this procedure provides only temporary relief and is reserved for respiratory distress or abdominal pain. When the patient is taking diuretics, monitor the level of sodium, potassium, and chloride and bicarb, monitor renal function, their BUN and creatinine, and routinely and check their diuretic dosage. Observe for signs of fluid and electrolyte imbalance, especially hypokalemia, which can be manifested by cardiac dysrhythmias and hypertension, tachycardia, muscle weakness. Water access may cause lethargy and confusion. Observe for and provide nursing care for any hematological problems, bleeding tendencies, anemia, increased susceptibility to infection. Assess the patient's response to altered body image from jaundice, spider angiomas, palmar erythema, ascites, and gynecomastia. The patient may experience a great deal of anxiety and embarrassment about these changes. Explain these phenomena and try to be a supportive listener. Provide nursing care with warmth and help to maintain their self-esteem. If the patient has esophageal or gastric varices, observe for signs of bleeding. If hematosis occurs, a patient for hemorrhage, call the physician and be ready to assist to control the bleeding. The patient may have to be transferred to ICU. Balloon tamponade may be used in patients with refractory bleeding that is unresponsive to band ligation or sclerotherapy. When band tamponade is used, the initial nursing test is to explain the procedure, check the balloon for patency, and it usually the physician's responsibility to insert the tube. The gastric balloon is inflated approximately 250 mLs. The tube is secured by placement of a sponge or on the nostrils by a nasal cuff. For controlled bleeding, the esophageal balloon is inflated. A spirogonomy is used to measure and maintain 20 to 40 millimeters of mercury, and the position is confirmed by X-ray. Nursing care involves monitoring for complications. If the gastric balloon breaks or dilated, the esophageal balloon slips upward, you can have asphyxiation. Keep scissors at the bedside in case they have to be cut. Minimize regurgitation by oral and pharyngeal suction. The patient is unable to swallow their own saliva. Encourage the patient to expectorate and provide an emesis basin. Frequent oral and mouth care is needed. What nursing priorities would you have for DL in relation to encephalopathy? The focus of the nursing care is a safe environment and to control the formation of ammonia. Assess their level of consciousness, pupils, sensory motor abnormalities, hyperreflexia, asterisks, or motor coordination, fluid and electrolytes, and the effect of the treatment measures. Assess the neurological status every 2 hours, institute measures to prevent constipation, encourage fluids, monitor for GI bleeding, and control factors known to precipitate encephalopathy that could, especially dehydration and opioid medications. DL recovers from her hepatic encephalopathy and is ready to be discharged. What teaching should be provided and what benefit would the social worker have? The patient with cirrhosis is faced with many possibility serious life-threatening complications. They should be taught to avoid over-the-counter drugs such as acetaminophen. They should have abstinence from alcohol. The social worker can help by providing some resources. Explore their attitude regarding alcohol and cirrhosis. Care should be maintained so that the person is able to communicate and does not feel uncomfortable relieving, letting you know what their problems are. Any questions, please let me know.